Well, thank you everyone for joining us. My name is Denny Morrison. I am your host for today. This is good morning or good afternoon, depending on where you happen to be located. First, a couple of housekeeping details. All attendees will be muted and the cameras will be turned off for the webinar. We'll be answering questions at the end of the webinar. So please submit those through the question app function on the app. It's likely that we won't get to all the questions, but those that we don't will be answered in the follow-up materials, including copies of the slides and a replay of the webinar. So please use the chat or the question function on the app to submit questions. So let's discuss today's webinar. There are few things that we do in behavioral healthcare that are more important than suicide prevention. Many of us who were trained as clinicians were trained to believe that suicide is inevitable if someone is highly motivated, and that if it is an unfortunate cost of doing business for providers. The Zero Suicide Initiative has shown that neither of these are true. And today we are fortunate to have three wonderful panelists representing different parts of the behavioral healthcare spectrum, covering the Zero Suicide Initiative, technology that can assist clinicians at suicide risk reduction, and a provider perspective that is integrated the two. Our presenters today are Barb Gay, Associate Director of the Zero Suicide Initiative, Hattie Tracy, President and CEO of Coleman Health Services, and Eleos Health, co-founder and CEO of Eleos Health. I will let them further introduce themselves, starting with Barb, and then Hattie, and then Eleos. Barb, please take the floor for a moment. And go ahead and introduce yourself, Barb.
Hello.
Now we can hear you. Oh, you're muted again. Okay, Barb, while you figure that out, Hattie, why don't you introduce yourself while Barb is working on her introduction.
Great. Hi, I'm Hattie Tracy, President and CEO for Coleman Health Services.
Okay, Barb.
Hi there. Sorry about that. Barb Gay. I'm the Associate Director for the Zero Suicide Institute.
Okay. And Eleos?
Alon Jaffe, CEO and co-founder with Eleos Health. Really excited to have everyone tuning in and for our great panelists and moderating. So thank you, Dr. Morrison. Over to you back, Barb.
Yeah, we showed the agenda a moment ago. So Barb, why don't you go ahead and start us off?
Okay, great. Thank you so much. I appreciate everyone joining today and the opportunity to talk with you about the Zero Suicide Framework and to learn about this great partnership that we have just started and looking at how do we use technology to better support the work of organizations that are looking to improve suicide care. So I want to just do a little bit of background with you to know who we are from the Education Development Center and what the Zero Suicide Framework is. I will say that my slides, though, are not advancing. There we go. Be a little patient for them to follow along. So you'll see here the Education Development Center is where the Zero Suicide Institute is housed. EDC is an international nonprofit, and we focus on education, health, and workforce challenges. Our Zero Suicide Institute is one of the three projects that we have in the EDC Solutions arm of EDC. And what we've done here with our EDC Solutions work is combine three issues that we know are extremely relevant and of utmost importance today: healthcare, suicide prevention in healthcare, substance misuse prevention, and social emotional learning. We're going to focus on the work of the Zero Suicide Institute and the Zero Suicide Framework. So you'll see that in that middle panel, and we'll move on and I'll show you the work that we do at the Institute, where we focus on both zero suicide as well as a training that's called AMSR, Assessing and Managing Suicide Risk. Both zero suicide and AMSR are focused on the well-being of the workforce. And this is exactly where this wonderful new partnership comes in. As we talk about system change and organizations supporting the providers that care for those at risk for suicide, We look to this technology and this partnership to do exactly what we're looking to do, which is support those who are providing the care. Staff manage acute patients. They manage more patients than they have in the past, and there's workforce shortages. And we're very excited for sharing this new partnership and these resources with you to see how you can bring this to your organization to improve the outcome for the patients, but also help improve and support the workforce that's providing this care with you. We're going to take a look at the Zero Suicide mission. It'll pop up here on the slide. And what I want to highlight for you are a couple of pieces that really speak to the work that we're talking about today. And that this is a systems-wide transition for improving safer suicide care. Oftentimes, and Denny spoke to this in the beginning, we talk about what's the practitioner's experience and education and their responsibility in providing the care. The Zero Suicide Framework is unique and different in that we say that this is a place to look at how the entire system supports the healthcare that's being provided for those at risk for suicide. So it's a culture-wide shift for the entire organization, and it identifies that every person working in the organization has a role to play in improving the outcomes for those at risk for suicide. The other key piece is the bullet there in the middle about evidence-based clinical care practices. Using the evidence-based practices is key to improving outcomes for patients. Finding out how you know that you're using these, how do you ensure that your system is actually using them with fidelity, that practitioners are adhering to those practices, has always been a struggle. And this partnership is one of the things that I'm most excited about because organizations, practitioners themselves, supervisors, we can use the data to see how is this working. And then we can look to see what else could we do differently. Why we target it in healthcare is always a question. Suicide prevention actually is something that is at the community level. We all understand that. What's different about the Zero Suicide Initiative is the identification that we can do something specifically and very targeted with our healthcare interventions. Let me show you why. So from data, we know that individuals who have made a suicide attempt were in healthcare systems. And largely what that says to us is either they were not identified as being at risk for suicide or they weren't receiving the care that they needed. And that's why we're focusing specifically on healthcare and the systems as the entirety. How do we help individuals receive the care that they need related to suicide? You will see and you'll hear today some examples about how zero suicide is being implemented in healthcare systems, like many that you're representing, and you'll see what the results are that they're gaining from this system change. The zero suicide model is unique, but I want to point out that it doesn't stand alone. It integrates really well with other initiatives that your healthcare systems may already be taking on. And you get that cumulative effect of strengthening all of those systems and approaches that you're taking. So I think that the idea here with this partnership is that this adds on as well. So this is a great area to look at. How can you use this new technology for improving suicide care outcomes, but other outcomes that your organization may be working on with your patients as well and your staff? I've talked about the Zero Suicide Framework, and now let me show you what it actually is. So the Zero Suicide Framework has 7 elements. These 7 elements operationalize the safer suicide care, which focuses on a continuous quality improvement model. As I mentioned, it goes beyond individual practitioners and providers. It's transformational care at the system level. You will see these 7 elements, how they connect, and they are in a circular pattern. And that's really important because they do need to all be taken on together. Not all at the same time, but we do need to consider how they all fit and flow together. LEAD is the system-wide culture change commitment to reducing suicide. And in LEAD, we talk about how to create a team that will guide the zero suicide implementation. A key piece of having a good zero suicide implementation team at your organization is making sure you've got different members from the organization represented on the team, including senior decision makers in the organization, clinical supervision, direct care providers, your IT department, as well as making sure you have the voice of lived experience on the team. And we're going to talk a little bit more about lived experience and share some resources as a follow-up about how you go about doing that. But really key to keep in mind that lived experience on the implementation team might be different than when you're using peer support staff, both very important in the zero suicide implementation. But you'll see again, this is a great way of how it comes together, because we move to train. We're talking about making sure that everybody in your organization, including roles like peer support specialist or administrative support, all team members feel competent, confident, and are able to provide care. So different levels of training for different individuals within the organization, so they clearly understand their role in the system of providing care to those at risk for suicide. Engage speaks to engaging all, I jumped ahead, identify. We have to do screening, and I know that was a question that came up today. So identify is where we're screening all patients to identify those who have a risk of suicide, and then moving on with a full suicide prevention or suicide assessment for those that have a positive screen. The zero suicide model in Engage talks about creating a suicide care management plan or a suicide care pathway. So those that are at risk for suicide know what their plan of care is, they're involved in creating their care plan, and that all team members who are providing care also know what that care plan is. So good communication and engagement for patient and providers. Specifically treating suicidal thoughts and behaviors using treatments that are evidence-based for suicide care. Oftentimes we know that the treatment that's provided is for other diagnoses such as depression and anxiety, but we've missed the opportunity to treat directly the suicidality. And that's what's spoken to here in the treat section. Transition is about good care handoffs, warm handoffs, moving from just providing referral information and actually making connections to the next level of care for the individual, making sure that they've made the good solid connection and that there is a handoff in place so that we don't have any gaps for the individual that's receiving care. And then improve. We talk about improve, but as you see, it connects right back up to this lead. We need to put in the data. We need to see what the data is and what it's telling us so we know if patients are getting better, if our staff have the resources they need, if what we've put into place, if our policies, our procedures, our action plans are actually getting us to the end result that we're intending to see. So this continuous quality improvement model that I spoke of in the beginning, we want to, we often think of zero suicide as not something that you'll start and stop. But then when you take on an implementation of zero suicide, you'll continue with the improvement process. You'll learn from what you do and do better and adjust as you see what your data is telling you and where you focus next. So doing all of this, there are resources for it. I want to just point out for you the Zero Suicide toolkit and the resources that are available. So you know, okay, so how do we go through understanding what is in each of these elements and how do we actually implement them? I'm so thrilled that you get to hear today from Coleman about how they're doing this in their organization. You can read on the website other systems that have done this as well. You can get samples, you can get ideas. You can see a number of webinars and recordings that also can be shared with others in your community or in your workplace to kick off this conversation of how do we change care and how do we do it differently going forward. One of the key tools that we have on the website is the organizational self-study. The organizational self-study is free for all systems to use. And we suggest you do that at the beginning of your zero suicide implementation process, and then come back to it in future times to get a baseline, to get a comparison to your baseline measure. I think when you are able to take some time and look through the toolkit, read about things on the website, when you hear this story today, you'll realize that you're likely doing a number of the recommended practices within the zero suicide framework, but it's about how do you make them better? How do you improve? How do you do more? You'll also find with the organizational self-study that there is an action plan template that you can use on the website as well. And that will help you then take that data from the organizational study and create a plan for how do we begin, where do we get started, which of the elements do we focus on first? And then you can use that to monitor your progress throughout the course of the implementation. I actually think I'll pause here talking about zero suicide itself. I'll make sure we don't have any questions. And then I know we'll have some chance to come back later and talk a little bit after you've heard about the technology and the experience and how these all fit together. So I think I'm ready to hand it back. Thank you.
Before we go to Elon, I want to just remind our new joiners that you please submit your questions through the question function on the app, and that the slides, a replay of the presentation, and all the questions that you have submitted that we don't answer verbally will be responded to in the follow-up email. So thank you. And now let's hear from Alon Jofi.
Thank you, Danny, and thank you, Barb, for that great introduction. My name is Eleos Health. I'm one of the co-founders and the CEO with Eleos Health. And I'm really excited to show you kind of a glimpse about the technology, what we're doing, and how is that intertwined with the work that both Barb and Hedy are doing in Coleman. So Eleos Health, our mission and kind of what we're doing is we are helping clinicians to focus on what matters most. And that's, of course, providing the best care possible to their consumers, to their patients and members. The way we do it is we're actually digitizing the 6,000 words that are being exchanged between a clinician and a member in a normal therapy session. We're digitizing that and providing a few different value proposition or outputs from these conversations. The first output, which relates to what Barb just said, is that challenge in terms of how do you quantify the evidence-based interventions and technique that happen in that session. So Eleos Health quantifies that, zero in on exactly what happened. I think a nice way to imagine that, and I'll show you that in a second in a demo, is this is like an X-ray scan of that conversation. And you can really start to understand what happened, what were the topics that were discussed. So it really helps clinician just get a snapshot of what happened, and in 30 seconds being refreshed and ready for their next appointment with their client. An additional value that Eleos provides to clinician is really reducing the documentation and administration burnout and burden. We know that the demand is higher than ever before, and Eleos takes the conversation and automatically summarize it and produce a compliant progress note or a baseline for such progress note and put it into the clinician EHR. We are very keen on not changing anything in the clinician workflow. We embed on top of existing EHR. We integrate into existing telehealth. This can also work for in-person, so the clinician doesn't need to change anything in their current workflow. And lastly, this is really about supervision. Because the conversation is being digitized and based on the organization policies, a supervisor can get access and provide comments and feedback to the clinician on what happened in that session and really streamline the entire supervision process. This is, of course, HIPAA compliant, HITRUST certified, SOC 2 certified, and is being kind of worked together with the consent from the patient. We are very happy to support our growing customer base, and of course, working with Coleman Health Services is kind of a key strategic partner of us. Our main providers that we work with are community behavioral health centers across the country, and also with a few national partner organizations such as the Zero Suicide Institute. So I think this webinar and this presentation really bring it home in a way how Eleos is intertwined into clinician daily workflow and help make sure that the work that the Zero Suicide is doing in the framework is actually being quantified and the feedback is being delivered to the clinicians. With that, let me jump into the demo. This is going to be a very brief and quick demo, so I'm not sure we'll be able to cover everything. Feel free to reach out to us to do kind of a more proper demo and more in-depth demo if you're interested in hearing more. But in essence, what you're seeing here is one of the EHRs that we are embedded with. This is actually my avatar by NetSmart, but it can be any web-based EHR. And if I'm the clinician, I'm gonna go ahead and kind of search my client name and open the patient chart. The first thing I'm gonna see here is really outcome measurement. And Hattie is gonna talk later about which screeners they're using in Coleman. In this example, you can see PHQ-9, and we know, of course, the last question or item number 9 on the PHQ-9 is around suicidal thoughts, but this can be any patient-reported outcomes. So one of the things we're doing is actually sending these screeners and outcome measures automatically to the members to collect that and present it very in a very easy to understand way to the clinicians. I'm again the clinician. I'm going to click over here on launch session. This button and a lot of the other functionality that you'll see is actually how Eleos is embedded on top of the EHR. We again can embed with any EHR vendor, and the process is very, very quick and easy. No really IT resources are needed either from the vendor side or from your side. So I'm going to click here on launch session, and for the sake of this demonstration, I'm going to launch a telehealth session. Mary and Al have been talking and provided services. And now I really want to go and kind of complete my note. So I'm going to search for individual progress note. And I have, the individual progress notes popping up. I'm going to go down. And here I can really see the AI kicks into life in a way, looking at this session intelligence screen. So here in this example, I can see how motivationally interviewed was quantified. Number of reflection, open-ended questions, closed-ended questions, clinician talk time. You can see how the techniques are being quantified. And Barb talked about the importance of using evidence-based techniques to provide the best care possible and reduce suicidal attempts. So this really provides a feedback system to the clinician where they can really see, hey, what happened in that session? Which intervention did I use? The only person who can see this, by the way, is the treating clinician. So they can really see and hone in terms of what happened and understand what is going on. They can also see the different themes. What was this session about? And of course, if suicidality is coming up, this will be presented here loud and clear for the clinician to pay attention that this was a common theme throughout this session. The clinician can also go in here and search for specific keywords or sentence that she remembered that was mentioned. You can scroll through and just click and jump into that point of time, or look at the most frequent keywords that came up. In this example, exam, I can click on that and actually go back and hear that point in time in the session. Important to mention, there's also a version of the Eleos product that does not keep the recording of the session, which is our scribe version, so that can be utilized as well. Now what the clinician is doing is really kind of finalizing their note and making sure that everything that happened in that session, everything that was quantified by Eleos in this session is in this note. And also here we have two versions. The first version is just the Eleos provide you with the baseline of the note, like you can see here. Everything that is written here was generated by our AI. What we've seen is a lot of clinicians like to start from scratch and in a sense just build their note. So they can go here into the data section, and on the right-hand side, you see the key moments. this is what the AI picked as the most important element in this conversation. And they can just read this, add this to the note. The engine also picked up that validation was delivered and problem solving, add this to the note, and of course, add changes and review that, go into the assessment part. We can see that the patient was engaged in the session, add this to the note, add the outcomes part to the note, which is, of course, is extremely important, and go back to plan and add here from this drop-down option. And as you can see very quickly, the note is being ready to submit. So we're actually seeing across the board between 30 to 40% reduction in documentation time based on this functionality. I can close this. And one last thing I'll show in terms of just kind of leadership perspective is really the ability to have a bird's eye view on what's going on across the organization. When we're thinking about, hey, we've implemented the zero suicide framework, we want to really understand what's going on across the board, across the organization, we can look at the evidence-based ratio. So the percentage of the sessions delivered by our staff that actually utilize evidence-based treatment. And that can also inform the level of care that we provide, and also looking at on the clinician level. Everything you see here is optionality. So some of these components can be included or can be excluded, depends on what you as a organization want to include in your product. So a few data points just to kind of point out. On average, we're seeing the median time to complete a note is being reduced from 10 minutes to 5 minutes. The median time to submit a note is within 24 hours. We're actually seeing that we're asking the clinicians who are using Eleos to rank how good do they think our suggestions are. So we see the average rating is 4 out of 5. And when you analyze the complete note, close to 50% of that note was actually generated by Eleos. When we're looking at client-reported outcomes, we have processed tens of thousands of assessments by now. And when you're looking, for example, at this PHQ-9, we are seeing across the board that because clinicians are utilizing more evidence-based techniques and have that feedback system in place, we see a reduction in symptoms across time. And we're actually seeing around 30% increase in usage of evidence-based techniques, which I think is really, really exciting. I see here a quick question from the audience, and I'll kind of finish up with that and provide and kind of, Denny, give it back to you. So yeah, the clients need to provide their consent if you're using the version of the product where you're recording the conversation. There's an additional version of the product which does not record the session. You still get the suggestions, you still get the different analytics, but we just don't keep any recording and the session is not recorded at all. You can think about this as a medical scribe in a way. And in that version, you do not need to collect consent because there is no recording. So this is really, I know it was very quick, but we just want to give you a taste of what the technology can do and how you can bake in it quantifying evidence-based techniques, quantifying the zero suicide model. And now I'll kind of hand it over back to Danny and Hattie to hear how this is actually being implemented in the field. So thank you, everyone.
Great, thanks, Alon. And this, to me, it's fascinating, the technology that's being used here. So now we've heard kind of from the two first presenters about what zero suicide is and how it works and how the Eleos solution works. And now we're going to hear from Hattie Tracy from Coleman Services about how they are using these technologies. So Hattie, take it away.
Thanks, Denny. Welcome, everybody. I am trying to move my screen forward and remember that I have to be patient so that if I try to move too fast, it won't work. So I wanted to give a brief overview of Coleman Health Services. We are a behavioral health, both mental health and substance use organization in the state of Ohio. I wanted to just put up our mission and vision so you can get a good overview of kind of what's important to Coleman as an organization. And I think some of the things that you will see on there is we talk a lot about continuous learning and improvement. And that's really where Eleos and Zero Suicide come in, because we have a strong focus on making sure that we are utilizing evidence-based practices so that our clinicians are well trained and so that clients are getting the best services that they can. So I also thought, excuse me, that it would be important for you to see what our 7 core values are as an organization. Again, because I think that really plays into a lot of our decisions to move forward and really focus on what can we do to better address individuals who are having suicidal thoughts, ideation, plans, and intent. And I also thought it would be interesting for you all to be able to see that we are pretty spread out geographically. So when we talk about the implementation of Zero Suicide and using this program, and we talk about it being a systems change, and that there can be some difficulties when you're talking about how do you change your systems, both from a program model, but also from a technology model, that it would be helpful for you guys to have a good overview of kind of how spread out we are as an organization. So we serve about 30,000 individuals annually. About 43% of the individuals we serve come from a Medicaid background and typically have multiple struggles with social determinants of health, technology being one of those, transportation, getting into services. And then again, about 68% of the individuals that we serve have an annual income of under 16,000 annually. We have about 850 employees as an organization with multiple staffing challenges, which is probably not new to anybody else. But I think as we talk about the technology and how we can utilize that and some of the evidence-based practices, that's a core part of how we talk about how do we address some of the staffing challenges we have in this. So again, an overview of the services that we provide. We have 2 988 call centers for the state of Ohio, as well as we do text and chat for the entire state. For 988, we provide services to adults, kids, mental health, SUD. We also have 24/7 mobile crisis services for adults and kids and 4 crisis stabilization units. So we really focus on how do people get access to care, and then how can we ensure that they have access to care on an ongoing outpatient basis as well. So this just really gives you an overview of the types of services that we provide as an organization. So in 2018, we partnered, and I realized after I did this, I'm never very good at making sure I explain what the acronyms are. So I'm going to explain them now and just apologize for not putting it in there. We partnered with OMAS, which is the Ohio Mental Health and Addictions Services Organization for the state of Ohio. And we were awarded a 5-year SAMHSA Substance Abuse and Mental Health Services Agency Zero Suicide grant, and that happened before I was in Coleman. And so really the idea behind that grant is how do we implement the Zero Suicide model within Coleman to make sure that we are doing what we intend to do, which is save lives. Really, I have a strong belief that our staff are first responders when it comes to saving individuals' lives, and I think we need to change that framework. So when we talk about some of the services that we added, I think Barb talked about making sure that we have the warm handoffs. We have hospital and jail liaisons. So those individuals are embedded within the hospital systems and in the jail systems. And the idea is that they are connecting with the individuals who are inpatient or are incarcerated and are doing that warm handoff and are connecting them to outpatient services upon discharge. And we have high-risk transition teams that those individuals who are being discharged are tracked on that team for 30 days and or longer, depending on how many services they follow up with. They have to hit 3 services and engage in 3 different appointments before we take them off the high-risk transition team. But after that, they continue to stay on our high-risk tracking and our electronic health record for up to a year after, so that we have pretty set standards of how much time you are and how often you are following up with these individuals that are deemed high risk. Because we think that's a really important piece of this, is being able to identify those individuals within your electronic health record and to track them. When we talk about training, all of our staff are trained in CALM, which is counseling on accessing lethal means. Our therapists and case managers are trained in AMSR, which is assessing and managing for suicide risk. We have staff who are mental health first aid trainers, and we also trained quite a few of our administrative staff on question, persuade, refer. So again, when we talk about it being system-wide, everybody should feel comfortable being able to talk about suicide. Are you having suicidal thoughts? Are you having that ideation? You know, do you have a plan? Do you have intent? I think too often clinicians aren't well trained in school, and it becomes problematic. And they don't feel comfortable having those conversations. So the implementation of zero suicide for us was really important in enhancing individuals' ability to talk about suicide. And then process improvement. Again, we have the high-risk tracker and our electronic health record. We also created our implementation of our clinical pathway for individuals experiencing suicidal thoughts. And we actually worked with Zero Suicide to really review that and let us know what we were missing. We implemented the Columbia screener at every visit. So that is done at every visit with every client that comes in. And depending on how that score, that can trigger completing the full assessment and or the safety protocol. And then we've also implemented caring contacts. So, and as Barb was talking, there are also quite a few other things that we have done that align nicely with zero suicide that I had forgotten that we had done. I think it's one of those things where we're in our 5th year. Sometimes it's hard to remember all of the different processes we have put into place around this. So really the next piece is talking about, and Barb mentioned this, is really talking about how do you improve over time, right? How do you improve those services and what do you do next around quality improvement? And for us, that's really where Eleos is coming in to help us analyze the data and really look at the individuals that have been receiving services at Coleman who have died by suicide, and looking at the data within their charts. And I don't know, Alon, if you want to hop in here and kind of talk about what you all have done. I believe there were 50 individuals whose charts you guys kind of went back and pulled the data from and really ran your reports.
Yeah, thank you, Hetty. So yeah, what we've done is we wanted to do kind of a brief analysis of some of the metrics that we're seeing that were captured in the HR, in the conversation around these consumers, and really compare these findings to a control group of consumers who were treated in similar care settings, in outpatient care settings. So we have ran our natural language understanding engine to search for therapeutic interventions, both in terms of frequency and type, as well as looking at the themes and topics. Just to give some demographic data of these 50 people, as you can see, the majority were male, around 40 years old, and in terms of their employment status, the majority were unemployed, but were actively looking for work. So that's just to give you kind of a very brief overview about the demographic. And what we've actually seen is a few interesting insights. What you can see here on the right are the most common topics that came up: substance use, relationships, communication skills, coping skills, recovery from substance use, and setting up personal centered goals. As you see, some of these topics are actually clinical interventions. And then we quantified the percentage of these topics or interventions that appeared in the Coleman group versus in the control group and the difference. So for example, we see that substance use and problems with relationship, as shown in mentioning also in communication skills, were really the dominant topics for people who died by suicide. When you compare that to the control group of similar consumers that were treated in similar care settings. And although substance use was really kind of predominant topic in the population, the use of coping skills and path to recovery was a bit less than what we see in the control group, as well as setting up person-centered goals for each consumer. So, Hattie, that's kind of, I guess, the analysis that we've done, and would love to also hear your take in terms of how do you see this from kind of managing the organization.
Yeah, absolutely. I think one of the things that was really helpful was, one, being able to really run the demographics, and it gives us a good idea of what is the target population that we should really be focusing on, and who do we need to be doing more with, and really looking at, okay, we know that it is males between the ages of 40 and 50, really 30 and 60 years old. So when we talk about the services that we're providing, what do we need to do differently there? And I have talked to Dror at Eleos and said, oh, based on this, I would like this information now as well, because I think it will really help us as we talk about training our staff and making sure that they are doing the CSSRS every visit and are having these conversations, that we really educate them on what makes somebody high risk, so that they can look at that and have a greater understanding of, look, this is what we're seeing in our own data. It's not just somebody else's data. This is Coleman's data. And I think on the next slide that you brought up, I think we're used to knowing that substance use plays a pretty large role in this. But I think when I go down to looking at like the coping skills, setting up person-centered goals, and then it's very clear that as an agency, we need to do better at that. And, very specifically, it's something that we need to retrain our staff on and say, look, if this is not happening, then this is going to impact their results of their treatment. And we have very clear data showing us that. I think we do a root cause analysis on every individual who dies by suicide within Coleman, and we go back and talk with the individuals, but being able to quantify this data and be able to say, these are the patterns that we're seeing across, and these are the changes that we need to put in place. This is part of the QI process to make us a better organization and to make sure that our clinicians have the tools that they need to go these next steps, I think for me is really important. And I think one of the things that I'm excited about is that we have not yet implemented Eleos as far as doing the documentation and the augmented intelligence. I'm excited to see how these scores and this changes as we implement that intelligence. Because part of me also says, I know that my clinicians are burnout and are tired of having to document everything. And so, is what they have documented really actually what happened in the session? And so I think it will be great to see once we implement Eleos, how some of this information changes over time. And I think, the part that you talk about it improving the use of evidence-based practices by 30% when somebody is, getting immediate feedback on the session that they're having, I think will also help us continue to improve and continue to save lives, which is really one of the core reasons why we're here, why we're in the field. So for me, I'm really excited about the opportunity to see kind of the before and then what happens after we implement, because I just think there's a great opportunity for our organization and for the individuals that we serve to do better and get better and to turn out better clinicians. I think that's important. We need to make sure that we are giving the clinicians the skills that they need and everything that we can do to make their jobs a little bit easier during very difficult times.
We're going to jump into questions in a minute, but I had one on that particular slide. So if you would go back to that one, one of my favorite sayings is knowledge without data is opinion. And that with this, we're getting data, and this is very fascinating and preliminary data, we know that. But I'd like to hear Alon and Patty speculate just a little bit about where this might take us. I mean, what kind of things, once you get implemented, once the data starts kind of rolling in, this is very preliminary, and where this might take us. When I think about Eleos, I think of it as a clinical decision support system on steroids. That its goal is to help clinicians be better tomorrow than they are today, and help them, give them tools to focus on the things that only they can do, and not the minutia of administration and data and implementing notes and all that stuff. So using these data, I mean, kind of. And I know I'm not asking you to predict accurately, just speculate. What could we do with these data to help clinicians get better?
So I'll start by saying that I 100% agree with you, Danny. I think technology role is to just help clinician make their life easier, right? It's not to replace clinician clinical judgment. And for us, the way we view kind of the future of this is, once we're running this diagnosis, if you will, of the organization, understanding, what metrics we can improve and what our metrics are really relevant to the specific organization that Hetty's people are seeing, we can then take these insights and put them into the product, and to make sure that, for example, when we know that the clinician is going to see someone with a high risk, like Hetty just mentioned, let's make sure that in the conversation, you're hitting on 1, 2, 3, right? And we can actually, guess what, quantify it and close the loop, right? And when I'm just speculating and thinking, forward, imagine that we can even, analyze the conversation and prompt to the clinicians, hey, maybe there are 10 minutes left. Maybe it's time to kind of just make sure that you have time to set up personal goals for the rest of the conversation, right? So I think we're gonna move. What we're gonna see is we're gonna see how AI plays a role in moving from, first of all, quantifying the data, which is where we are today, to really decision support, which is what you talked about, Danny.
And I would just add, I definitely agree with what Alon has said. And, in my perspective, I believe we all have workforce shortages right now. So anything that I can do to help train our staff to make them more effective and more efficient, so they're not getting burnout, I think for me is really important. And we know that the workforce shortage is not going to go away anytime soon. So we really have to focus on how can we utilize technology to make us better, to make us more efficient, and not necessarily be afraid of it. So I think for me, it is definitely really looking at moving forward. How can you utilize technology to, make your system better and stronger and provide some relief to your therapists, case managers, prescribers that are in the field every single day.
Yeah, we're going to jump into questions now. And I had one that kind of really riffs off of what Patty was just saying, and that is, we have been kind of down this path before. There have been several technologically driven upheavals in our industry. Just the implementation of electronic health records, for one. The widespread use of telehealth from COVID was another. Is what we're talking about here with augmented intelligence is something different, or is it really just another iteration of technology kind of playing into our space?
The way we see this is there are two infrastructure layers today in terms of behavioral health IT, right? And that's what you talked about, Dennis. Basically, the first layer is the medical record, which was digitized. The second layer is telehealth and access to care, which was digitized. We believe that in behavioral health, the conversation is actually the treatment, right? We're actually treating people by talking to them. And so the next untapped territory is how do we digitize conversation to help drive workflows, automations, efficiency. Not too long ago, I was in a conference, I think, by National Council for Wellbeing, where, you know, there was this opening keynote statement said the challenge for all of us today is the workforce challenge, right? And I think that's what Hedy talked about. And when clinicians have less time, and guess what, they're burnt out, it's more difficult, I guess, to pay attention to how do we implement the zero suicide framework, how do we really deliver evidence-based care. So I think, yeah, technology will play a role to put the clinician back in the center of things and not to have clinicians work for the technology, but the technology work for the clinician. I think that's how we envision technology kind of playing a role in the next immediate or short-term future. So, Danny, I hope that makes sense.
I think it's, you know, it's one thing to be burned out because you're seeing a lot of patients and doing good work. It's another thing to be burned out because you're burdened with administrivia, you know, and anything we can do to offload that stuff and let clinicians do what only they can do, that's got to be a help to the workforce issue, I think, in my opinion. I had a question for Barb, and this is, I'm curious, why don't more organizations use zero suicide? I mean, it seems like it's a best practice to me, and it's adopted pretty widely, but it's not universally adopted. What do you think prevents people from adopting ZSI?
You know, I think some of the biggest challenges stem from the conversation just now, the workflow, the things that are required of organizations and systems to take on, and the shortage of the workforce. I think also what, though I would say to that is that there's just the understanding of what does it really mean to look at the zero suicide framework and implement it. It can look daunting. It's a great little circle with seven elements. I will tell you, when you click on the website, each of those elements breaks into more tabs, and it can feel a bit like, wow, how do I do all of this? And that's the reminder that you're likely already doing it. From that early data that I presented, we know individuals that are at risk for suicide are coming into the organizations that you're working in and you're leading today. So really the idea here is not to do, you're not adding something else, but it's how do you do better? And that organizational self-study, I'll mention it again. I think it's the key piece of understanding where are you today and where do you need to go with the zero suicide implementation. So how do you mentioned a little bit, got to look back at what you've accomplished. We talk about celebrating all of that, acknowledging what you already have in place, and then looking for how do you do better? How do you do the additional pieces? So I think it's helping folks, Denny, understand that it's also not a standalone. This is a piece of work that supports that clinician and the system and the patients beyond suicide care, and it does really integrate nicely with others, like trauma-informed care. Quite easily integrates with trauma-informed care and the other work that organizations are doing. So realizing that that's also going to be an outcome, and it's not one more thing.
Yeah, I think it's kind of, that reminds me that old joke is how do you eat an elephant? And it's one bite at a time. If you try to look at the whole thing at one time, it's daunting. But these are philosophical and strategic changes for organizations, aren't they? I mean, you don't just say I'm going to do a little bit of ZSI. I mean, it's got to be, and that starts at the top, doesn't it? I mean, the leadership, right, like somebody like Hattie,
exactly,
has to say, hey, folks, this train's heading north, and we're going to go on a northbound direction.
And it really starts with that conversation. I admire Hattie's leadership in doing this work, and to say that we aren't doing it all exactly as we're going to do it in the end, that I heard her saying today, this is a process, it's a journey we're on. And when we have that data and sharing your own organizational data, so the opportunity here is to make this very personal to your system and to your provider and your patients, and to say, here's where the data is, good and bad. But it's what our data is, and it's what we do with it next. So that conversation really sets the culture, starts that conversation change for really how are we going to talk about suicide differently today than we've ever done it in the past.
Yeah, we're giving you some information here about how to reach out to people, but we still have a couple of questions, and we still have a few minutes of time, I think. So I'll get the hook if I go long. This is for everybody, but particularly for Alon. In this and throughout today, we have talked about the term augmented intelligence as opposed to artificial intelligence, and that term is actually what has been recommended by the American Medical Association for healthcare-oriented machine learning systems. Why are we using that term alone? Why augmented versus artificial intelligence?
Yeah, I think it's a great point, and we're now seeing more and more kind of white papers and ethics guidelines around the use of artificial intelligence and augmented intelligence in the field of healthcare. The reason we're using, and I think the best practice is to use augmented intelligence, is because it literally augments the clinician. It is not here to replace the clinician. And to me, when I hear artificial intelligence, it's a bit, I don't know, scary. It's a bit daunting. Like, I don't know really what that means. Artificial, I don't know. I imagine like the Terminator or something. And when I hear augmented intelligence, I think this is really what it's all about. And how do you augment clinical workflows to allow providers, in our case in behavioral health, focus on what only they can do and what matters most, right? There is a nice chart, I don't really remember the numbers right now, that is showing the growth in administrative role per growth in doctors and clinicians, right? And you're actually seeing that the growth in administrative role is exponential. It's not linear to the growth in clinical roles. And I think our care system today requires just more and more administrative stuff from clinicians, from case managers, from providers, and the technology didn't caught up. For a lot of providers, the best tool they still have is their notebook, which is great, but it doesn't help a lot to automate processes. So I think augmented intelligence is really all about how do we help the people in the front line improve the quality of life and focus on what matters most. To me, that's what augmented intelligence means. And it has nothing to do with artificial intelligence. That, again, for me, it's a lot about replacing and a lot of just more scary stuff that does not convey really the true meaning of what the technology is all about.
Yeah, I think, I'm like you, it's like when somebody says artificial intelligence, every science fiction movie I ever saw pops into my mind. And exactly. The Terminator and HAL in 2001. I mean, all these where technology has gone awry, and it's kind of hard to not go down that ugly path. I'm going to try and squeeze in one more question, Hattie. This is for you. Can you kind of then quickly say what have you heard or what do you anticipate to be Coleman's clinicians about this technology?
What do I expect to hear from our clinicians?
Yeah, how do you think they're going to accept the idea of using augmented intelligence as part of their workflows?
I mean, we have been talking to them about this for a while, so I hope that we will have some that are excited. We will have some that are skeptical, but I think that's always the case. I think you want to focus on who are going to be your early adopters and who are going to become your subject matter experts, and then you slowly bring the rest of your staff along. I mean, to think that everybody is going to come running out of the gate and say this is fantastic is not realistic. So for us, it's really about how do you find those early adopters that will be your subject matter experts and will help bring people along. So it's a process.
And champions for you.
Yes.
I want to thank you all for doing this today. We want to thank our audience for attending. It's been a wonderful opportunity. Especially want to thank our presenters, Barb Gay, Patty Tracy, and Alon Joffe. And I want to also thank Jennifer Gridley for all the work that she's put in getting this thing organized from Eleos. Our presenters have graciously agreed to provide their email contact information on that last slide you saw, and that we will be sending out this information and the answers to questions that were not answered during the session. So thank you all for joining us, and I hope you have a great day.